So last time we were talking about a little bit the Bohr's effect and the saturation curve. So the hemoglobin saturation curve, this is a really important concept. There's going to be a few questions on the exam based off of whether or not you get a shift to the right versus a shift to the left. So a shift to the right, that's going to be something you see during exercise, right? So when you're more acidotic, when your pH levels are lower, meaning that you're more acidotic, as well as when your temperatures are increased, you're also going to get that shift to the right. Other things that can affect that, we discussed briefly last time, 2,3-BPG, also known as 2,3-DTG, depending on which terminology you prefer. But know that that molecule is going to help stabilize deoxyhemoglobin. So if you have an increased level of 2,3-BPG, that's going to stabilize the deoxygenated version of hemoglobin, so you get a shift to the right. Now, shift to the right means that you're letting off more oxygen in those tissues. That's why I want you guys to focus on this as being something relating to normal physiology and exercise. Because when you're exercising, you get an increased amount of lactic acid, right? So that means that you decrease your pH. You're also going to be increasing the temperature in those tissues. What does that mean? That means that you need more oxygen in those tissues. And so because of that, your hemoglobin is going to be able to release more oxygen. And so when you release more oxygen, then you get the shift to the right, okay? Versus the shift to the left, that's going to be associated with decrease in temperature as well as increased pH. So if it's colder, if your tissues aren't really metabolically active, right? So you're more of like a resting state, you're going to have more of an alkalotic state. It's not going to be as acidotic, so the pH is going to be higher. Then the hemoglobin doesn't need to release oxygen at those tissues. And so hemoglobin is going to be more saturated at those levels. And so you'll get a shift to the left. So that's under normal, like, physiological function. That's if you're exercising or if you're at rest. But you can also apply those concepts to other conditions as well. So take, for instance, shift to the right. Low pH. A patient is acidotic for some reason. Maybe they're overdosing on drugs, overdosing on fentanyl. Or maybe they're having an asthma attack and they're not able to get as much ventilation through their lungs as possible. They're going to start accumulating carbon dioxide. They're going to become more hypercapnic. Then you're also going to get a shift to the right as well. Okay, so that would be a pathological type scenario where you get a shift to the right. Temperature, think about hyperthermia. Okay, so if you're out jogging or you're hiking in the desert and you run out of water, all of a sudden you're heat stroke, right? If you're heat stroked, the hemoglobin saturation curve is again going to shift to the right. So you're going to get dumping of oxygen in places where you don't want the oxygen being dumped at. Now, for the other side, think about a condition where you're becoming now hypocapnic. You're hyperventilating, maybe you're having a panic attack, maybe you're having anxiety, and then you're breathing really rapidly. Now you're breathing off all that carbon dioxide, and then you're going to become more alkalotic. Then you're going to get a shift to the left. Now, temperature-wise, maybe you're stuck in the Arctic for whatever reason. Maybe you're exploring the Arctics. You get stuck out there. Now you get really cold. You become hypothermic. If you're hypothermic, again, you're going to get a shift to the left. That means that your oxygen hemoglobin curve shifts to the left. That means your red blood cells and the hemoglobin in the red blood cells are going to hold on to oxygen molecules with more affinity. Okay, so I'm going to run through a couple of sample questions later on when we do our quizzes, and then maybe I'll just write it out so that we can kind of go over it together so you can understand that concept a little bit better, because I know it can be a little confusing. So this is kind of an overview of hyperventilation versus hypoventilation, where you would see a change in your pH levels if you become more acidotic versus more alkalotic. If you're more acidotic, shift to the right. If you're more alkalotic, shift to the left. And then, if I remember correctly, this is where we finished last time. So adult versus fetal hemoglobin. Now, with adult hemoglobin, you have 4 different chains, 4 different globulins, and each of those are going to be made up of 2 alpha and 2 beta chains. So that's going to be adult hemoglobin. For children, not children, but for the developing fetus, it's going to be alpha and gamma. Those are going to be the two major globulins, or type of globulins. Now, with fetal hemoglobin, think about a child developing in the womb. Oh, not the womb, the womb. The child needs a lot of oxygen in order to develop properly, right? And so where does the child get the oxygen from? The child's not just breathing. The child is getting oxygen from mom. So whatever mom breathes in is what's going to eventually make its way to the developing fetus. Now, because the child's not breathing on its own, it's going to have to be able to attract oxygen molecules more readily. So in other words, you want the affinity for fetal hemoglobin to be greater than adult hemoglobin, right? Because it needs to take that oxygen from mom's blood and bring it onto its own blood. Okay, so fetal hemoglobin is going to have a lesser affinity. Actually, it's not going to bind at all to 2,3-BPG. Because remember, when 2,3-BPG is present, it's going to allow for stabilization of the deoxyhemoglobin. In other words, it's going to stabilize the hemoglobin without oxygen on it. Okay, so you want to maximize the amount of oxygen that gets onto the fetal hemoglobin. That's going to be one of the major differences. In terms of practical application for this, aside from just developing the fetus, fetal hemoglobin is administered to patients who are undergoing sickle cell crisis. If you guys remember when we talked about sickle cell anemia before, sickle cell anemia, you have defective hemoglobin, and so you get that sickling shape, and that's the sickle red blood cells get trapped into different tissues and get trapped into the capillary beds. In order to counteract the effects of sickle cell anemia, you can actually administer exogenous fetal hemoglobin to those patients so that it can help them deliver oxygen to their peripheral tissues more readily. So that's one thing to keep in mind about fetal hemoglobin. So let's talk about carbon dioxide transport. Now, the majority of the carbon dioxide that's going to be transported in your blood is going to be in the form of carbonic acid. And carbonic acid is going to be formed through the enzyme carbonic anhydrase. So carbonic anhydrase converts carbon dioxide and water into carbonic acid. So that's the reason why when you have too much carbon dioxide in your blood, you become acidotic, is because of carbonic acid buildup. That's the main thing that's going on with carbonic acid. And then I'm going to show you a little bit of how bicarb and chloride ions can exchange. That helps to maintain the pH balance in your blood. So it kind of acts as a buffer. The other thing that you can see with carbon dioxide is that you can indeed see carbon dioxide binding to hemoglobin. It's not going to bind on those iron units. It's going to bind on the free nitrogen units. I'll show that to you guys in a second. And then you also have a small amount of carbon dioxide that remains dissolved within the plasma. So this is what's going on with carbonic acid over here. 70% of all of your carbon dioxide is going to be converted into carbonic acid. And then when it's in that carbonic acid state, then you're going to see it freely dissociating into hydrogen ions as well as bicarbonate. And when it does that, the hydrogen ions can be further buffered, right, so that it can help control the pH levels of the blood. But bicarbonate can actually be transported out of the red blood cell into the plasma with the exchange of chloride ions. And so we call that a chloride shift. And this is one way that you can see the pH levels also being buffered as well. So this helps to control and maintain the pH within the blood. So this is going to be one of the major states in which carbon dioxide is going to be transported. It's going to be through carbonic acid and carbonic anhydrase. 23% on average of carbon dioxide is going to be bound to hemoglobin. So you're going to see some carbon dioxide bound to hemoglobin. But like I said, 70%, that's the majority. It's going to be in carbonic acid. And then just a small percentage, about 7%, is going to be transported through plasma. So this is your hemoglobin. This is one heme globulin, right? So it's got all these different carbon chains. You got the iron that's sitting in the middle of the hemoglobin molecule. And then you have these little free nitrogens surrounding the iron. Oxygen is what binds to the iron. Okay, iron, when you have oxygenated hemoglobin, it binds to the iron. Carbon dioxide is not going to bind to the iron. carbon dioxide is going to bind to hemoglobin, but not at the iron site, because you don't want carbon dioxide competing with oxygen for that binding site. You want oxygen to be able to easily bind to iron whenever it's present. And so what happens is that carbon dioxide does indeed bind to those free nitrogen groups. So here's a little image of what that looks like. So you got a free nitrogen group, here's carbon dioxide, and that's basically what it's binding to, just the free nitrogen. So this is important because you don't want carbon dioxide outcompeting oxygen. Now, let's talk really briefly about the Haldane effect. The Haldane effect basically describes how levels of oxygen are going to change the affinity for carbon dioxide. So let me show you a graph here. This graph does a really good summary of what the Haldane effect does. So these are different various levels of oxygen that you might be subjected to. So down here, if your oxygen is at 100 millimeters of mercury in terms of partial pressure, then you're going to have less binding of carbon dioxide to hemoglobin. The more oxygen you have, the less carbon dioxide is going to bind. That's because oxygen can outcompete carbon dioxide in binding to hemoglobin. The less oxygen you have, the more carbon dioxide is going to get bound to the hemoglobin molecule. So that's basically what the Haldane effect describes. Nothing too crazy. Just know that the more oxygen you have in your blood, the more it's going to bind to hemoglobin instead of carbon dioxide. So here's the summary of everything we talked about. So on the bottom here is going to be oxygen. This is going to be taking place at the level of the alveoli. So is this external or internal respiration? External respiration, good. So this is external respiration at the level of the alveoli. So when you're breathing in, you're going to have a lot more oxygen in the alveolar sac, and it's going to be able to diffuse directly across the membrane onto oxygen, because remember, it's going from high partial pressure to low partial pressure. It's just simple diffusion based on concentration gradients. And then the opposite is true. Over here, you have carbon dioxide, which is mostly going to be in the form of carbonic acid. So this is going to be 70% of what's going on with carbon dioxide. Most of it's in the form of carbonic acid. Then it gets it gets turned into carbon dioxide plus water, and then the carbon dioxide gas can be diffused across the membrane with ease. And then in terms of the carbon dioxide that's bound to hemoglobin, only about 23% of that is bound to hemoglobin. That also gets diffused across. So this is when you're releasing carbon dioxide back into your alveoli so you can breathe that off through exhalation. And then this is going to be internal respiration at the level of the cells, right? So at the level of the cells, especially in cells that are deplete of oxygen and are undergoing a lot of metabolic activity, you're going to have the concentration at the level of the cells being a lot less. And so because the concentration of oxygen is much higher within hemoglobin, it's going to just, through simple gas diffusion, cross over the membrane into those cells that need oxygen. And then the opposite is true for carbon dioxide. So you just get basically an exchange of carbon dioxide for oxygen. Cool. Any questions on all that? It's nothing really too crazy, but just make sure you understand the concepts. Understand that carbon dioxide, mostly in the form of carbonic acid. You should be good if you understand that concept. Know that carbon dioxide is associated with acidosis. So if you're hypercapnic, you become acidotic as a consequence. So let's talk about the respiratory centers of the brain. There's multiple different regions of the brain that help to control respiration. Okay, so you actually have higher cortical centers that are going to be responsible for respiration, and you also have lower regions in the brain, for instance, in the brainstem, that are going to help control respiration as well. Higher cortical centers, that's going to be all voluntary. Think about like you want to take a breath in, that's something that I can actually control, right? You can control that as well. Those are going to be voluntary higher cortical centers. You also have the limbic system, which is going to be especially responsible for things like emotions, things like aggression, right? Especially if you're talking about the amygdala. So a lot of your more like primal type instincts will be moderated by the limbic system. So for instance, if you get hyper emotional, you might start hyperventilating. So that's going to be something that might help to control respiration as well. Other regions might be the hypothalamus. Remember, the hypothalamus is going to be associated with like helping to release cortisone, things like that, right? Cortisol. So you might get like a stress reaction, which is going to be moderated by the hypothalamus as well as the pituitary gland. Those regions can also affect respiration. Now, as you start getting lower and lower towards the brainstem, then those regions are really going to be mostly involuntary, right? So those are going to be involuntary. It's going to be parasympathetic as well as sympathetic activation that's going to help mediate respiration. So we'll talk about all those regions right now. So in your brainstem, you have three major areas. You have the midbrain, you have the pons, and then below that, you have the medulla. After the medulla, then you go off into the spinal cord. But the two major regions in your brainstem that are responsible for respiration are going to be pons and medulla. Within your medulla, those are going to be kind of like the pacemaker regions of your brainstem. So there's two areas that are really important, the VRG and the DRG. VRG is the ventral respiratory group that sits anterior to the brainstem. Dorsal respiratory group sits posterior to the brainstem. Okay? The dorsal respiratory group is what all of us are experiencing right now. We're just kind of sitting here, we're relaxed, nothing too crazy is going on. It's going to be responsible for what we call quiet inspiration. It's literally just you inspiring. That's when it turns on. Then it turns off during expiration. And expiration is a passive process. You're just basically allowing the elastic recoil of your pulmonary tissues to just allow oxygen and air to be removed from your lungs. And by oxygen, I mean mostly carbon dioxide because that's what you're breathing out. The ventral respiratory group is going to be more forced inspiration and expiration. This would be activated if you were like going on a jog or if you're getting chased by a lion or something like that. That would be the ventral respiratory group. The way that you can think about that, dorsal behind, ventral in front, maybe you want to run forward. So the ventral respiratory group would get activated. That's one way that you could probably conceptualize it to help you remember. Then, as you get into the higher area of the brainstem, you get into the pons. The pons has two major regions. You have the pneumotaxic center and you have the apneustic center. The apneustic center is going to be responsible for long inspiration. If you take a long breath in, that's going to be moderated by the apneustic center. The apneustic center basically stops the DRG from turning off because the DRG is turned on during inspiration. If you prevent it from turning off, then you're going to inspire for a longer period of time. The pneumotaxic center is a little bit different. It's going to inhibit the apneustic center, and pneumotaxic center gets activated if you need to increase the rate of your respiration. So if you need to increase your respiratory rate, that's going to be moderated by the pneumotaxic center. It's going to turn off the apneustic center. It's going to prevent long inspiration. It's going to make inspiration shorter. This could be taking place, for instance, if you're like hypercapnic and you need to breathe off more carbon dioxide, then the pneumotaxic center would take over and would help to allow for faster respiration. So let's continue. Oh yeah, and by the way, dorsal respiratory group, passive, quiet inspiration. It's mostly going to be affecting the diaphragm, because remember, 70% of your inspiration is going to be moderated by the diaphragm. A little bit is going to be moderated as well by the external intercostal muscles, right? And so that's the dorsal respiratory group activates the diaphragm, you breathe in, and then it turns off, and then the diaphragm relaxes, and then you exhale. Now, if the ventral respiratory group gets activated, that's going to start recruiting some of the accessory muscles of respiration. So if you're like out there on a jog and you're trying to breathe in really rapidly or exhale with more force, then you might actually recruit, like the scalene muscles, serratus anterior muscles, rectus abdominis muscles to help you exhale more with more force. Okay, so that's what the ventral respiratory group is doing. Cool. So let's go into more detail about all these different regions. Within your medulla, you also have what we call the pre-Botzinger complex. Now, it depends on what illustration you're looking at. They'll show the pre-Botzinger complex in different regions. Like, for instance, this illustration shows it's kind of hanging out in the middle of the ventral respiratory group. This other illustration shows it kind of hanging out on top of the ventral respiratory group. But it doesn't matter. It's within the medulla, and what it does is it acts as sort of like the pacemaker for respiration. The pre-Botzinger complex is what regulates the DRG. Okay? The DRG is, remember, quiet inspiration. You're just hanging out. You're just breathing in normally. That's going to be, the pacemaker is going to be set by the pre-Botzinger complex. Now, when the ventral respiratory group is activated, remember, that's forced inspiration and forced expiration. Okay, so you're going to be breathing in a little bit more aggressively. This is going to be during stress, during exercise. All right, so if you're out there jogging, this is what's going to be activated. It's going to be the ventral respiratory group. And this kind of reiterates a lot of that, but this other regions are also going to affect the dorsal respiratory group. So the pons, we're going to talk about in a second. That's going to be your apneustic center, pneumotaxic center. Those could affect the dorsal respiratory group. Peripheral and central chemoreceptors. We're going to talk about that in a little bit. Chemoreceptors are going to be responding to changes of the chemical composition of your blood. So changes in the levels of oxygen, carbon dioxide, as well as the pH levels. So peripheral mostly responds to oxygen. Central chemoreceptors are mostly going to respond to carbon dioxide. I'm going to show you that in a second. It's going to be found within your brainstem. It's going to be responding to changes in the CSF, the cerebral spinal fluid. Stretch and irritant receptors. I'm going to tell you about irritant receptors later on, but that's like, if you inhaled something noxious and then all of a sudden the bronchioles constrict, that can also affect the respiration rate as well. So in order to protect the lungs, protect the alveoli, respiration is also going to be affected by chemical irritants. And then higher brainstem, we were talking about limbic system, hypothalamus, all those regions can also affect the dorsal respiratory group. So this is quiet breathing. Quiet breathing, you're just taking a breath in. You have contraction of your diaphragm, right? So it straightens out. You increase the overall volume within the thoracic cavity. Pressure decreases. Air gets pushed in. Okay, so that's going to be inspiration. Then the dorsal respiratory group turns off during expiration. So expiration is just a very passive process. With forced breathing, which is going to be associated with the ventral respiratory group, you have inspiration. And then for expiration, the VRG gets activated, so it allows for forced expiration of air. And it's going to be involving more of those accessory type muscles to help push the air out of the lungs. So let's talk a little bit now about the pons and those regions that are within the pons, the apneustic and pneumotaxic center. So these regions collectively are going to be referred to as the pontine respiratory group, but I want you to know each of the different groups, okay? I want you to understand what the apneustic center does as well as what the pneumotaxic center does. So let's just look at this image over here because it does a good summary. So with the apneustic center, so the apneustic center is going to sit directly below the pneumotaxic center. The apneustic center is going to send projections down into the dorsal respiratory group. The apneustic center, long inspiration. So it's going to inhibit the DRG from turning off. So it allows for more air to come in over a longer period of time. Now, if you were having some sort of requirement to increase your respiratory rate, that's when the pneumotaxic center, which sits above, turns that apneustic center off. Okay? So it inhibits the apneustic center, so now you have more rapid respiration rate. And then stretch receptors. Because you don't want to overinflate your lung, because you might eventually get a tension pneumothorax, or you might get some sort of perforation of pneumatic tissues. The Herring-Brauer reflex is the reflex that basically prevents the overinflation of the lungs. Okay, so that's the Herring-Brauer reflex. Let's talk a little bit about irritants. Now, say you're in a World War I soldier and they're using chlorine gas, which is one of the chemical warfare weapons that they used to use back in those days. You inhale chlorine gas. It's a chemical irritant. what is your lung going to try to do as a response? It's going to bronchoconstrict so that it can help protect the alveoli, because the alveoli are very delicate tissues. You don't want to damage those. And so irritants are going to help with bronchoconstriction, and it's going to also result in a coughing reflex as well. So you can try to get all those like irritants and noxious stimuli out of your lungs. Stretch receptors, that's basically what we just talked about, the Herring-Brauer reflex. So that's what would affect the stretch receptors. Once it overstretches, overinflates, that's when the Herring-Brauer reflex kicks in to prevent hyperinflation of the lungs. So now let's talk about chemoreceptors. So you have both peripheral and you have central chemoreceptors. The common theme amongst those chemoreceptors is going to be pH, right? They're both going to respond to pH levels, i.e. low pH, right? When you have lower pH, you're acidotic. That means you have too much carbon dioxide. That means you need to increase your respiratory rate to breathe out that carbon dioxide. You need to increase your oxygen levels as well. Peripheral chemoreceptors, those like peripheral, that means outside of the central nervous system. Those peripheral chemoreceptors can be found within the carotid bodies, right, within your carotid arteries. Those are going to be moderated by your accessory nerve, so cranial nerve, the glossopharyngeal nerve, cranial nerve 9. And then the vagus nerve, cranial nerve number 10, that's going to be found within the aortic arch. And in the aortic arch and the aortic bodies, you're going to be able to respond to changes in mostly oxygen levels. Okay, so if you're hypoxic, that's going to stimulate the chemoreceptors peripherally. Centrally, it's going to be responding to carbon dioxide levels. And central nervous system, you're going to think CSF, cerebral spinal fluid. That's going to, so changes in carbon dioxide in the CSF is going to stimulate the central chemoreceptors. That's all over here, peripheral and versus central chemoreceptors. So this is what that looks like. So take, for instance, within your arterial blood, right? So this is going to be peripheral. If you have low oxygen, if you have too much carbon dioxide resulting in acidosis, that's going to increase your ventilation rate. Central, that's only going to be responding really to carbon dioxide. So the more carbon dioxide you have in your CSF, the more acidotic it becomes, then that's going to also increase your respiratory rate. So pretty straightforward stuff. Nothing really too crazy. And then hyper versus hypocapnia. So when you hear those terms, that just means changes in carbon dioxide levels. Hypercapnia, too much carbon dioxide. Hypocapnia, too little carbon dioxide. Both of which can actually be kind of bad. It's kind of like a sweet spot when it comes to the levels of carbon dioxide in your blood. So with hypercapnia, we're thinking acidosis. You're thinking hypoventilation, right? Remember my heroin addict patient example, right? They're overdosing on heroin or maybe fentanyl or something like that. They're undergoing respiratory depression, right? So the respiratory rate significantly slows down. They get an accumulation of carbon dioxide. They become hypercapnic. They become acidotic. Okay, so that's going to be what affects one example that affects ventilation. Something else, on the other hand, would be hyperventilation. So that if you breathe too rapidly, right? Maybe you're having a panic attack. If you're breathing too rapidly, you're exhaling way too much carbon dioxide too rapidly. Now you become hypocapnic. Now you become alkalotic. Okay, so that's going to be respiratory alkalosis. These are some of the effects that can happen if you're alkalotic due to respiratory alkalosis and if you're hypocapnic. So if you start hyperventilating and you have significant changes in your carbon dioxide levels, you can get all sorts of consequences, not just lightheadedness, dizziness, but you can also faint as a consequence too. One of the main reasons this happens is because changes in the pH levels actually result in vasoconstriction of the cerebral vessels. So vessels that bring blood to your brain, those start to vasoconstrict, and that's one of the reasons why if you're hypocapnic and you're breathing too rapidly and you become alkalotic, this could be potentially an issue, right? It could make an individual pass out, lose consciousness. And you can also get these like weird spasms. You can get abnormal flexion. things like that. But mostly you're thinking neurological type results as a consequence. And then this is a summary that I included that goes over all those different regions within your brainstem that are going to be important. So no pre-Botzinger complex, that's your respiratory pacemaker, right? So that's the respiratory rhythm. Dorsal respiratory group, quiet respiration. That's going to be quiet inhalation, right? You're just breathing in. It turns off when you're breathing out. VRG, that's be forced exhalation, right? So that's when you're exercising or in a more sympathetic type situation. Apneutic center, long inspiration. It turns off the DRG, or sorry, it prevents the DRG from turning off, so it keeps it on, so you have a longer breath in. And then the pneumotaxic center, that would be stimulated if you need to increase your respiratory rate, so you breathe much more rapidly with the pneumotaxic center. Any questions? All right, let's go ahead and do some quizzes, questions, and then after that, we'll go on to begin GI. Oh, no. Okay. All right, awesome. Go ahead and hit start. Believe it or not, some people actually do hike the Arctic. I have some friends that actually do that kind of stuff. So, what would that do? All right, so that's a pretty decent spread going on over here. So if you're hypothermic, you're going to have low body temperature, right? Remember, with low body temperature, if you have low temperature, you get shifting to the left on the saturation curve. Okay, so you get shifting to the left. Why does it shift to the left? Is because you have more oxygen binding to hemoglobin. Okay, in other words, less oxygen is going to be released from that hemoglobin. All right, does that make sense? All right, I'm going to do a bunch of these with you guys. I might even do some handwritten ones just so you can get a better feel for what these curves look like. All right. So, what happens to the pH when you are exercising? All right. So you start what? Yeah, exactly. So if you have an accumulation of lactic acid, pH goes down, right? So that means you're becoming more acidic. So pH levels are going to decrease. And what happens with decreased pH levels? Shifts to the right. More oxygen is going to get released from hemoglobin at that point. Okay? We're going to go over more of these because I see that this is kind of a difficult concept for some of y'all to understand, which totally understandable. It is kind of confusing. Just understanding how it works with exercise, that's going to help you a lot. So we're going to go over some more of those. All right, good. It looks like most of you all got this correct. So fetal hemoglobin, remember it's alpha and gamma instead of alpha and beta. Because of that, it's not going to bind to 2,3-DPG or BPG. So what's going to happen with that? So if you don't get stabilization of the deoxyhemoglobin, that means you're going to get more oxyhemoglobin. Okay, so with more oxyhemoglobin, that means you have more percent saturation. You get shifted to the left as a consequence. And O2 binding affinity is going to be increased as a consequence of that. Does that make sense, guys? All right. We'll do more of these questions afterwards. Good. What's the percentage? 70-ish. What's the percentage bound to hemoglobin? 20 something percent, 23-ish. How much is dissolved in plasma? 7%. How much is going to be carried on thrombocytes? None. Cool. Nice. Good. So basically it's inverse, right? So if you have increased oxygen, decreased carbon dioxide binding. Okay? Decreased oxygen, increased carbon dioxide binding. That's the Haldane effect. Sure, this doesn't apply to any of you guys in this class, right? Good. So the dorsal respiratory group, that's quiet inspiration. That's what's basically happening regardless. And that's going to be set by the pacemaker, which is what? You guys remember? The pre-Botzinger complex. You guys remember that? So that's all going to be taking place at the level of the medulla. Good. So ventral respiratory group located within the medulla. A couple more. Good. Pneumotaxic center. Shorter, more rapid respirations. Let's just do one more. All right, so if you think peripheral, you're thinking oxygen. Central, i.e. cerebral spinal fluid, you're thinking carbon dioxide. All right, so and do one. All right, congratulations, Hannah. High five. All right, so let me do something real quick here. I'm going to put on a blank screen. All right, let's run over some problems real quick here. So let's start with that whole oxyhemoglobin saturation curve. So 100, 100, and then let's do around 20 or so here. Let's do 50 here. Okay. Now, on the left side, this is going to be hemoglobin saturation. So hemoglobin percent saturation. Down here, it's going to be millimeters of mercury. I think that's how you do it. And that's going to be partial pressure of oxygen. Now, it doesn't go in a straight line, right? It goes in a curve. You guys remember why it goes into a curve in terms of like oxygen saturation? Yeah, as you add more oxygen molecules to hemoglobin, the binding affinity keeps on going up and up and up. Okay? So the curve is going to look kind of like this. Okay? So as you add more and more oxygen, you know what? There's a dip in there. Let me erase that real quick here. Let me do that one more time. Okay. And it's never going to quite go up to 100. Remember in that video I showed you? It kind of gets up to about 97% or so. It doesn't ever really get up to 100 because a lot of a small percentage of the blood is going to go to the conducting areas of the lungs to to actually provide oxygen to the lung tissue itself. But for the sake of simplicity, let's just assume that it goes up to 100. Okay. So what's going on over here? Why did I write down 20 over here? That's like an important number. It's like 20, 25-ish. This is 20 millimeters of mercury partial pressure for oxygen. So even at 20, you're going to get 50% saturation of hemoglobin. Okay? That's really important because if you're sitting in a room and it's like 100% partial pressure of oxygen, you have 100 millimeters of mercury of oxygen, you just pure oxygen in the air, then you're going to get close to about 100% saturation of hemoglobin. But if you're in a room that's only 20 millimeters of mercury of oxygen, you're still going to have 50% of your hemoglobin being saturated, right? So that means half of all your hemoglobin is going to be saturated with oxygen molecules. So that means that hemoglobin has a really high binding affinity for oxygen. Now, let's say that you are working out, you're exercising, okay? So what happens when you're exercising? What happens to your pH? Goes down. What happens to your temperature? Increases. So you get what? A shift to the right. Good. So let's draw that out. So now let's look over here at 20 millimeters of mercury. Now this number dropped significantly. Let's say that's around 20%. Okay, saturation. That means at 20% millimeters of mercury, if you're exercising, that means a lot more oxygen now is getting dumped off of that hemoglobin molecule. Right? Does that make sense? Right? Because you're trying to meet the demand of those tissues to be able to actually properly oxygenate them. Now, this could also happen with hyperthermia. Right? So if you get overheated, if you have a heat stroke or something like that, you're going to get a shift to the right. Low pH, that's going to also happen with acidosis, right? Right, so that could be respiratory or metabolic acidosis. If it's respiratory acidosis, you're not breathing properly, right? So you might be getting, respiratory depression, for instance. So that can happen in those conditions as well. But under healthy conditions, you're thinking exercise. Okay, that's the best way for you to conceptualize that. Now let's do the opposite, okay? So the opposite, temperature is decreased, pH is increased. So now you're alkalotic, okay? So now you get a shift to the left because of that, okay? So now look at this saturation curve. At 20 millimeters of mercury of oxygen, now you're way higher in terms of saturation of your hemoglobin. It's about like 75%-ish, okay? That's way higher. That means now you're sitting at like 20 millimeters of mercury of oxygen. Your red blood cells are going to be really saturated because they don't need to dump off the oxygen. There's not as much demand in a person that's at a resting state, right? Maybe your skeletal muscles are all relaxed. They become a little bit cooler in temperature. They're more alkalotic. What else can affect this? Low temperature. You're thinking hypothermia. Maybe you got stuck in the Arctic, like my example of a person hiking the Arctic for whatever reason. You might be hyperventilating, right? So you're breathing off all the oxygen. Now you're becoming hypocapnic, right? So reduced carbon dioxide levels. So that would be a shift to the left. So I hope this helps you understand a little bit the oxygen or the hemoglobin saturation curves. Any questions on that? Okay, now the other thing that I want to go over is pulmonary function test real quick. So let's do pulmonary function test. Let me change colors. All right, so let's do a pulmonary function test. So we're all just sitting here, normal, nothing really too crazy, so we're just breathing normally, okay? All right. What's this region here called? What's the term for that value of just regular breathing? You're just sitting here, normal breathing, nothing crazy. It's called what? Tidal volume. Good. So that's tidal volume. So that's normal tidal volume, normal respiration. Sits at around 500 milliliters of air. Okay. So that's just shy of a wine bottle. Okay. That's about how much air that you're breathing in. Okay. Wine bottle is 750 mLs. 500 mLs is what you're getting into your lungs. Now, what is this called? This section right here. What is that? Is that exhalation or is that inspiration? That's breathing in, right? So you're breathing in the maximum amount of air that you possibly can. You cap out right here at the top. That's the most you can accommodate in your lungs. What's that called? Inspiratory reserve volume. Okay, IRV. What about this portion right here down below? That's you breathe out everything you possibly can, right? So what's that called? Expiratory reserve volume. Good. What is all of this right here? That's everything you can breathe out, all the way to everything that you can possibly breathe in. Huh? Vital capacity. Good. Excellent. What is this region right here? It's the stuff that's left over. Residual volume. Good. What is all of this combined? TLC, total lung capacity. Okay? Now, here are some things that you're going to have to learn how to calculate as well. So let's change my colors. What is this region right here? So it's combining your inspiratory reserve volume plus your tidal volume. That turns into what? Inspiratory capacity. So IC, inspiratory capacity. All right. Now, what about this region right here? It goes below that, but it goes all the way down to the bottom. So it includes your residual volume. What's that called? So this is residual volume right here. Okay, what would this be? Huh? It's called the functional residual capacity. Now, when we look at capacities, if you notice, capacities involve a combination of at least two of these values. So your inspiratory capacity, that's your inspiratory reserve volume, plus your tidal volume. Functional reserve capacity is going to be your expiratory reserve volume plus your residual volume. Your vital capacity is going to be your expiratory reserve volume plus tidal volume plus inspiratory reserve volume. Total lung capacity is all those different values combined together. Okay? So just make sure that you understand these different variables, understand how to calculate for instance, inspiratory capacity, for functional reserve or residual capacity. Okay? So, oh, and then, yeah, that's it. That's basically it for the pulmonary function test. Are we good? All right, let's get into GI tract. If you guys have any more questions about that, we can go over it at my office for, what's it called? Review session. So, let's get into GI. We got 20 minutes. Let's try to plow through as much of this as possible. All right. So, for chapter 25, we skipped chapter 23, chapter 24. We're going to get to those later towards the end of the semester, so we're at chapter 25 now. By the way, speaking of the book, read the book if you want some more clarity on these ideas. The book is actually pretty dang good. I know that you guys get the digital copy. I personally don't like digital copies of books. I like the real thing. But, you know, regardless, try to read the digital copy of the book as much as you can, because it will go through a lot of these concepts and a lot in some great detail. So it's a good book. So let's talk about what we're going to go over in chapter 25. We're going to talk about just the physics of chewing and eating, so mastication versus deglutition, and then we're going to talk about different glands that are involved in the saliva productions and what those glands can also produce, not just saliva, but also like certain enzymes like amylase, for instance, that breaks down carbohydrates. We're going to talk about the movement of your GI tract, which is going to be due to peristalsis as well as segmentation. So we're going to talk about how that all plays into digestion. And then very last section, we're going to talk about some of the like hormones that are involved in controlling digestion. And then we're also going to talk about the role that the pancreas and the liver plays, right? Lots of different things that the pancreas releases in terms of digestion, lipase, amylase, protease. The liver is also going to play a very important role, especially in the digestion of lipids, right, through the production of bile. And then we're going to talk about the gallbladder and how the gallbladder has a role to play in the release of bile as well, and how it responds to things like cholecystokinin to help release bile. Now, there's a little section here that I included that different terminology for food as it makes its way through the GI tract. As you eat something, it turns into a bolus. As it gets into your GI tract and your intestines, it becomes chyme. And then once it gets excreted in the large intestines, it becomes fecal matter. Okay, so that's just some basic terminology. Another basic term is the alimentary canal. Alimentary is also another term for the GI tract. Okay, so if they're both going to be synonyms, different words for the exact same thing. And we're going to go into all these different organs throughout the course of chapter 25, which is going to be in 3 different parts. So let's just go ahead and get into it. So what does what's the functions of digestion? So the very first step is going to be ingestion. Okay, so that's going to be the buccal phase. You're just putting food into your mouth at that point. So that's just going to be basic ingestion, nothing crazy going on there. Then you're going to start processing food mechanically, right? So there's mechanical digestion, that's just crushing and shearing that can be taking place at the level of your teeth. There's also going to be some mechanical digestion taking place when you get into your stomach as well. As the stomach moves around, that's going to be involved in mechanical digestion plus chemical digestion, which we're going to get into later. Chemical breakdown, that's going to be chemical digestion. So it's going to involve all sorts of different chemicals ranging from hydrochloric acid to things like protease to things like lipase. Those are all going to be involved in the chemical breakdown of food. So you can break down lipids with lipase. You can break down carbohydrates with amylase. You can break down proteins with protease. Okay, so those are going to be different enzymes involved in that process. You also get secretion of different types of compounds. You can get secretion of water that helps to lubricate the chyme as it's traveling through the GI tract. You're going to also get secretion of hydrochloric acid, which is really important for chemical digestion, enzymes, buffers, salts, especially bile salts. Those are going to act as emulsifiers to help you absorb lipids, for example. And quick question, where do lipids get absorbed into? The what? Do you guys remember the term for that? You guys remember your when we got into lymphatics? Lacteals. You guys remember that? Is that what you said? Did you say lacteals? Okay, good. So that's going to come back to haunt us in a second. Absorption. So that's going to be absorbing nutrients. Lacteals would be a good example of where you get absorption of lipids, but basically just different compounds that are able to move across your epithelial layer, and then excretion. So that's going to be removal of waste. And we're going to talk about that at the very end of the 3rd section of chapter 25. I'm going to get back to the Bristol stool test, which is, in my opinion, one of the funniest things in medicine. One really weird thing that doctors and scientists love to do is do like weird food comparisons. And so the Bristol stool test is, I think, one of the most disgusting examples of that. So type 1 Bristol stool chart, so it goes from extremely constipated to runny diarrhea. And so at the more extreme end, you get little lumps like nuts. And as you start getting less and less constipated, it becomes sausage-shaped again, sausage or snake-shaped. I don't know who came up with this chart, but it's pretty freaking hilarious. So we're going to talk about excrement at the very end of this chapter. Fun times. This is one of the reasons why I would never personally want to be a GI doctor. I don't know why anybody wants to go into that field, but to each their own. So let's talk about the very first step, right? So when we are chewing, we're undergoing mastication. Okay, so be careful how you say that word. So chewing, mastication, pretty straightforward stuff. There's several muscles that are going to be involved in mastication. They call them the muscles of mastication. The major ones are going to be the masseter. So if you touch your cheeks, you clench in your jaw, that's going to be one of the major muscles you feel. That's the masseter muscle. Another muscle, if you clench your jaw and you touch your temporal area, that's your temporalis muscle. That's going to be one of the other major muscles of mastication. Inside your oral cavity area, there's going to be a couple other ones, lateral and medial pterygoid muscles. Okay, so those are all going to be the major muscles of mastication. You also have other muscles of mastication too. Some muscles, for instance, that help to open the jaw. Most of these are going to be involved in closing the jaw. You have other ones too that are going to open the jaw. So infrahyoid muscle, the digastric muscle. Don't worry about knowing all these muscles. I'm sure you guys get inundated with all these muscles when you are in your lab. So for the purpose of our class, just know that these are the muscles of mastication, and you don't have to go into super granular detail for that. So, but let's talk about glands. So the major glands, the first major glands that we're going to deal with are the salivary glands. So salivary glands are going to produce a lot of saliva daily. 1 to 1.5 liters of saliva. 1.5 liters, that's 2 bottles of wine, right? Because each bottle of wine is about 750 milliliters. You are producing 2 bottles of wine worth of saliva every single day. So that's a pretty significant amount of saliva. Most of your saliva is going to be produced by your submandibular gland. So the submandibular glands are going to be sitting lateral underneath your mandible. Those are going to be the majority of saliva produced in those glands. A smaller percentage, but still significant amount, is going to be produced by your parotid glands. Your parotid glands are going to be kind of adjacent to the masseter muscle. It's going to be below the zygomatic arch, which is what makes up your cheekbones. It's going to be anterior to your ears. Okay, so that's where the parotid glands are. That's going to be about 25% of all your saliva is produced in those glands. And then you have a little bit of saliva being produced by your sublingual glands as well. It's mostly going to be parasympathetically mediated. You do have sympathetic activation as well. So with parasympathetic activation, right, you think about parasympathetic as being rest and digest. What happens when you're resting and digesting? You're going to be salivating as well so that you can help lubricate the GI tract. Okay, so that's going to be part of it. So parasympathetic activation increases salivation. Sympathetic activation, on the other hand, is going to give you like cotton mouth. If anyone has ever taken like certain like stimulants, maybe like Adderall, drugs like that, those are going to be increasing sympathetic activity, reduces salivation. And so there's a lot of drugs that cause quote unquote cotton mouth. That's kind of what's going on with that. So you get a reduction in salivation. Other things to keep in mind here. So there's going to be a couple ducts associated with these different glands. So the parotid gland is going to be releasing saliva at the Stenson's duct, and that's going to be sitting right next to your second molar on each side of your cheek. Then your submandibular gland, that's going to be one of the major ducts at the frenulum of your tongue. There's going to be 2 sides directly adjacent to the frenulum of your tongue, and that's going to be the Wharton's duct. And then the sublingual gland is going to be the Ravinus's duct. Okay, so that's going to be a couple different ducts that You should probably know what the different ducts are termed for the exam. So let's talk about what salivary glands do. So they don't just produce saliva, but they also produce a lot of other things too. Some of the major components are going to be mucus, right? So you're going to have mucus. Mucin is going to be one of the things that helps to secrete mucus. So you have mucins. And then you're also going to have glands that are going to release certain types of enzymes as well. So serous cells, for example, are going to be responsible for releasing predominantly amylase. So when you're chewing on a piece of bread or a cracker, something that's like a carbohydrate, after a little while, it's going to start to taste sweet, right? Because you're breaking down a complex carbohydrate into its monomer sugars. Okay, so you're breaking it down into like glucose, for example. And so that's why it starts tasting sweet. So that's going to be what amylase does, and that's going to come from your serous cells. Now, the parotid gland, as I mentioned, is directly below your zygomatic arch. It's also anterior from your ears. That's going to be producing saliva as well as amylase. It's one of the major glands that produces amylase. And if you look inside your cheek at the level of your second molar, that's going to be where you find the Stenson's duct. Okay, so that's going to be this region right over here. So second molar, Stenson's duct. Parotid glands could potentially get inflamed. So if you had inflammation of your parotid glands, we call that mumps. Okay, the major virus that causes that is the mumps virus. So just keep that in mind. That's a clinical application of some of these glands here. Sublingual gland, that's going to be producing the least amount of saliva out of all those salivary glands, only 5%. Most of that's going to be mucus in terms of like composition, so water and mucus. It's going to act as like buffers and lubricants just to help lubricate food whenever you're chewing. And then in terms of the ducts that's coming out of, it's going to be the Ravinus's duct. And that's going to be, this is the frenulum of your tongue. It's going to be just on the lateral sides from the frenulum. Okay. And this is the Ravinus, who was the guy who originated the term. So he was a German physician as well as a botanist. So fun stuff. Pretty wild looking hair too. Anyways, moving on to the submandibular gland. So this is the one that's going to be producing the bulk of your saliva. So submandibular glands, that's going to be on the lateral sides just beneath the mandible. It's going to secrete lots of things. So mucins to provide mucus, glycoproteins. Also going to secrete amylase to help break down those complex carbohydrates. And then the main duct that it's coming off of is going to be right over here. It's going to be the Wharton's duct. Okay, so that's going to be the ones directly adjacent to the frenulum of the tongue. Okay. So these are this is what saliva effectively does. So lots of different functions for saliva. Most of it's going to be made up of water, but it's also going to have things like electrolytes as well. So different electrolytes like sodium, chlorine, things like that, chloride ions. Glycoproteins. So glycoproteins are going to be what make up mucus. So that's going to be providing lubrication and things like that. You're also going to find antibodies. So if you remember when we talked about the adaptive immune system, we talked about immunoglobulins, recall that the ones that are mostly associated with mucous membranes are going to be IgA. IgA antibodies are going to be found from anywhere in your oral mucosa, can be found in the mucosa of your GI tract, can be found in like the vaginal mucosa as well. So anywhere that you see mucosa layers, you're going to find IgA. You can also find IgG within your saliva. So that helps to prevent infections. It helps to fight off different types of antigens. You're going to find enzymes as well. We talked about amylase. You're going to see amylase, protease, things like that. Those are going to be found within your saliva. And then there's also going to be things like lysozyme. If you remember, we talked about lysozyme as being one of your primary defense enzymes. You're going to find lysozyme within your tears as well as in your saliva. Lysozyme helps to break down the gram-positive wall, the peptidoglycan wall of gram-positive organisms. So saliva, the major functions are going to be to provide lubrication, helping provide moisture. It helps to keep those chemicals dissolved. As you dissolve chemicals, that's going to help to increase taste as well. So it helps to stimulate taste buds, and it helps to provide sensory information at the level of the taste buds. And it's going to help to initiate digestion. So we talked about amylase. That's one of the major ones that's released by saliva. Also, things like lipase can help to break down lipids. So those are going to be some important chemicals that help to initiate chemical digestion of food. And then this is a good summary of the autonomic nervous system and how the autonomic nervous system affects salivation. So think rest and digest, parasympathetic response. You're going to increase salivation. Sympathetic response, fight and flight. You're not going to be, digesting anything, hopefully. So you're going to reduce the amount of salivation from sympathetic activation. So I didn't include this in your guys' slide. I put this in today because I thought it was, kind of an interesting condition. This is mostly a benign condition. It's called sialolithiasis. Sialolithiasis, it's literally just like stones. So these are like, they call them calculi. So these are stones that can block these different ducts within your salivary glands. And they can be extremely uncomfortable and very painful. Things that can help, some of the major causes, most common causes are going to be like dehydration, smoking, and there's also autoimmune disorders that can predispose an individual to get sialolithiasis. So Sjogren's syndrome is one example of that. In order for treatment, usually it's benign, so it doesn't really require much treatment. So hydration, maybe increasing like acidic type like foods that can help to break down these calculi. That can be something that can help. But if it gets bad enough, it could cause abscess formation. It could become infected, so you could get like superimposed bacterial infections as a consequence of that. So pretty nasty stuff. Now, very briefly, let's talk about swallowing. So there's three major phases when you swallow food. So the buccal phase is going to be all voluntary. That's just like putting food into your mouth. Okay, so that's going to be the buccal phase. Everything that happens after that is basically going to be involuntary. So the pharyngeal phase is involuntary. So is the esophageal phase. And when you swallow, this is called deglutition. Okay, so deglutition is the act of swallowing versus mastication, which is the act of chewing. Now, take a note of what's going on over here. You see that in this image, you see the larynx. This is the larynx right here. That's where you find, at the top of it, you find the epiglottis. That's where you also find the vocal cords. As you swallow, the larynx lifts up, and it helps to close the epiglottis over the larynx. So instead of food going down into your trachea, food is instead going to go down the esophagus. So that's what's going on with the pharyngeal phase. So it is 4:19. Let's go ahead and continue this next week on Tuesday. Have a great weekend, guys. If you have any questions, shoot me an email, okay?